Hello, I'm Denise Willis, Section Editor for Respiratory Care. This video will discuss the paper Post-Extubation Stridor in Severe COVID-19 by Abdallah and colleagues from the June 2022 issue. Post-extubation laryngeal edema and stridor are common complications from invasive mechanical ventilation that often lead to reintubation. Independent risk factors for post-extubation laryngeal complications include female sex, large endotracheal tube diameter, emergency intubation, and duration of mechanical ventilation. It has been reported that 60 to 80% of all ICU admissions for COVID-19 require mechanical ventilation, and that a higher viral load is associated with greater severity of lung inflammation. This study examined the prevalence of post-extubation stridor in subjects with severe COVID-19 and the association with viral load. Subjects with COVID-19 admitted to the ICU who required mechanical ventilation during 2020 were included. Subjects in the control group without COVID were admitted between 2016 and 2019 and required ventilation for more than 48 hours. Chart data was collected retrospectively and included the occurrence of post-extubation stridor or steroid treatment, whether intubation occurred pre-hospital, in the ICU, or was difficult, the endotracheal tube size, severity score, duration of ventilation, use of steroids prior to extubation, reintubation, and PCR testing results from tracheal samples. The primary outcome was audible stridor within 2 hours after extubation, and the secondary outcome was viral load assessment. There were 307 total subjects included, with 96 and 211 in the COVID and control groups respectively. Post-extubation stridor occurred in significantly more subjects with COVID-19 compared to controls, but the incidence of reintubation was similar between the two groups. Multivariate analysis adjusted for the severity score identified that female sex, a COVID diagnosis, reintubation, and prone positioning as factors related to increased prevalence of post-extubation stridor. Prolonged mechanical ventilation was not associated with stridor after adjustment. Stridor was significantly more common in subjects with a positive PCR on the day of extubation. In this figure for cycle thresholds, a low number of cycles indicates a large amount of virus and higher viral load, so you can see that subjects with stridor had a higher viral load, but the difference was not significant. Post-extubation stridor occurred more often in subjects with COVID-19 as compared to controls. Female sex, as well as reintubation and prone positioning, were also found to increase the risk for stridor. It is unclear if persistent viral shedding contributes to post-extubation stridor. Some of the study limitations were that only stridor was considered, and the incidence of post-extubation laryngeal edema may have been underestimated. Preventative treatment with steroids varied at the discretion of the provider, and not all subjects had PCR testing prior to extubation. The accompanying editorial notes the unique aspect of evaluating viral load and the significant association between positive PCR samples and stridor. Although higher viral load correlated with stridor, it was not statistically significant. The editorial suggested that the longer duration of mechanical ventilation, prone positioning, and the greater severity of illness in subjects with COVID-19 may have contributed more to post-extubation stridor than viral load. In conclusion, this study identified COVID-19 as an independent risk factor for a post-extubation stridor, and that stridor was associated with persistent viral shedding at the time of extubation. Thank you for your time. Be sure to follow Respiratory Care on Twitter and Facebook and subscribe to YouTube to be alerted for new content.